Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, current president of RhAPP, and today we're going to dive into a topic that's gaining increasing attention in clinical practice, the genetics behind low alkaline phosphatase and what it actually means for our rheumatology community. Low ALP can be an easily overlooked lab value, but as many of us are learning, it can also be a doorway into important genetic considerations and evolving diagnoses. To help us explore this landscape, I'm thrilled to be joined by Heather Mambretti, a valued RhAPP board member and someone with a deep passion for clinical education and rare disease awareness. Heather, welcome so much to the show. And before we jump in, can you please introduce yourself?
Sure. Thank you so much, Amanda. I'm happy to be here. I'm Heather Mambretti. I've been a PA in rheumatology for the past 12 years, and I am part of your RhAPP leadership team.
Well, we're so fortunate to have you. And I know you have a bigger interest in osteoporosis. I really struggle still after 18 years with osteoporosis, and I'm the first to say it's my weakest area, and especially trying to understand the secondary causes for fractures and osteoporosis. So I think you are the absolute perfect person to have on this podcast. I'm so excited to learn from you because I have to be honest, I am one of those people that have kind of ignored the low ALK phos levels. So let's just go ahead and get started. So can you explain?
Let's dive in.
Yeah. Can you explain the clinical significance of a low alkaline phosphatase value and why we should be paying attention to it?
Sure. So alkaline phosphatase is an enzyme that's found in the liver and the bone, and it plays a crucial role in bone mineralization. I think that's something that we as rheumatology clinicians really need to pay close attention to and learn how to investigate it, because these patients will show up in your clinic. They will sometimes present with vague musculoskeletal symptoms as well as bone-related concerns and dental concerns, and it's easy to miss if you don't have this on your radar.
What specifically should we, be looking for? Like what genetic conditions or mutations are commonly associated with this persistently low ALK phos level? And how do they differ in the presentation?
So a couple of things can be associated with this low ALK phos level. We have Wilson's disease and also celiac disease. But I think the primary consideration for us in rheumatology clinic is hypophosphatasia, the primary genetic condition that we should focus on. It is considered a rare genetic disorder related to the genetic mutation in the ALPL gene. And the clinical differentiation is important because we can have patients who are in the perinatal time of life, right after birth, even infantile hypophosphatasia that is within the first 6 months of life. And these folks tend to present with pretty severe symptoms. And it's more rare. It's approximately 1 in 300,000 live births in terms of the incidence of perinatal or infantile hypophosphatasia. But for adults, it's not that rare. It's 1 in 500 patients will present with adult hypophosphatasia. And these folks are going to be the folks that we need to catch in clinic.
So that's super interesting. So 1 in 500. So I've definitely missed this then.
I think we all have, honestly. They're in our clinic lurking. Yes.
So you mentioned, so when we see a low ALK phos level, you mentioned celiac. We should be thinking about Wilson's. That's copper, right? If I'm remembering from school.
Yes, okay. That is copper accumulation, but also you can see low ALP levels in Wilson's. And then celiac, you can see the associated ALP levels related to a nutritional deficiency. But the one we should really be thinking of top of the differential when we see low ALP is hypophosphatasia.
Okay. Thank you. That's, I think, a good clinical pearl because, maybe as part of our workup, we should be checking those other things as well. So from your experience, what are the clinical clues that would prompt us to pursue this further evaluation when we see a low ALK phos level?
Okay, so the clinical clues can be sort of vague and nonspecific at times. Anyone who has chronic musculoskeletal pain, lots of fatigue, but the specific things that ought to clue us in and turn on a little light bulb for us would be any history of a non-healing fracture or potentially losing teeth, like dental disease where they are losing teeth for no reason, potentially a history of nephrolithiasis because of an increase in calcium levels, or patients who have a history of CPPD type of flaring where you might be concerned about chondrocalcinosis in those patients.
Okay, that's super helpful. I mean, one thing I would say, it seems like everybody's fatigued and has, but that's, and has muscle pain. But I think, I can think about, people that I've seen that, I've diagnosed with maybe fibromyalgia and, they've had a low ALP and maybe I just kind of, ignored it. So I really appreciate your input because I think I'm going to look at things a little bit differently. Which is going to lead to my next question. How do you approach this diagnostic workup? Like what labs, imaging, or genetic testing are you considering the most valuable when you see these low ALK phos levels?
So one of the things I have had to retrain myself to do in terms of approaching this diagnostic workup is to, especially for those patients that have the musculoskeletal pain or fatigue, really make sure I'm going into a dental health history, which I haven't always done well. I like to keep HPP in my differential for anyone with vague musculoskeletal complaints. I pay particular attention to any lab value of low alkaline phosphatase. I'm usually repeating that lab, and then I'm going to go back and trend low alk over time, or low alkaline phosphatase, over time, and even request prior records if patients have had labs done with their primary care or perhaps another specialist. And I'm also taking a detailed family history. Do they have people in their family with any genetic history of low ALP? Do they have anybody in the family with fractures and dental issues who might be undiagnosed? And then I'm considering genetic testing for all of my patients who have a persistently low ALP and looking at the ALPL genetic testing options that are available to them. And I'm also considering, from a radiographic evaluation standpoint, evaluation of plain x-rays, looking for things like prior fractures that may not have healed well, or even signs of chondrocalcinosis.
Okay. And, you almost wonder if, those bone surveys that we can do would be helpful in this set of patients. When we're kind of thinking about ruling this out, or maybe fractures they didn't even know they had.
Correct.
So that's super helpful. And when you say like trending it over time, because like you said, anything can change, like you could see something low and then it goes back to normal. So what you're really looking for is it's persistently low, on multiple occasions of you checked, right?
This is not going to be a one-off reading where everything else has normalized. These patients will have chronically low ALP, and you can usually do some sort of trend feature in the lab, in the EMR, and you can look at over time, multiple levels of low ALP, and that's your patient where you want to really hone in on that diagnostic workup.
Okay. So we see a patient that has a persistently low ALP. We obviously are thinking about some of the other causes, which you mentioned, but really we should be kind of thinking about, this genetic disorder and potentially adding that to our workup for the patient, particularly if they've had a history of non-healing fractures, if there's a family history of genetic issues, or if they've had issues with like teeth falling out, you said, kind of, which doesn't really make sense. Did I get all that right?
Correct. And I think the dental history is kind of a key element because most of these adult onset patients will have kind of hard to parse out musculoskeletal symptoms, but the dental history, I can really kind of lock in that for me. So it's something that I've had to retrain myself to do when I'm thinking of the differential for these patients, and have tried to be better getting a dental history on most of my patients with general musculoskeletal presenting symptoms.
Well, I'll tell you, starting next week when I'm in clinic, I will do a better job because I really haven't with Sjogren's patients, I think about it, but like otherwise, I'm not asking those detailed questions, even if they have had a low ALP. So this is really super helpful. And I think it's really helpful to our listeners to understand that, we can order these tests and we really are responsible for our patients. And potentially, if you are managing their, osteoporosis or whatever it might be, like we really need to kind of think about this as our differential, and not even like osteoporosis or fractures, but those patients with these vague musculoskeletal complaints, etc. So you've kind of alluded to this, but what are the biggest misconceptions, would you say, or things that have been overlooked when clinicians encounter patients with low ALPs in their practice?
I think that one of the misconceptions that I myself held was that this was an extremely rare disease. And that might be more accurate when we're talking about the more severe autosomal recessive type infantile patient inheriting this condition. But for adults with HPP, 1 in 500 people is not that rare. I think the misconception is there that it's maybe more rare than it actually is. And I think we also tend to overlook some of the screening questions in our patients where we're trying to focus on management of their OA-related pain or fibromyalgia pain and dealing with their bone health. There's a misconception that we overlook some of the key findings for our HPP patients. And I think there's also a misconception that these patients are going to be lost to follow-up. A lot of times you can go back, and we've done this in our clinic, and how we found this particular patient population who meet criteria for HPP is we've done a lab trend. And this is something that we can potentially implement for our practice. Or your individual practice as a clinician, is you can pull data from the lab that you use in your office, and you can have them run a report for all the patients in the past 12 months, 18 months who've had a low ALP reading. And then you can go back, if there's 20 or 30 of those patients, go back and look, was this a one-off abnormality or was it a trend? And that's how we in our clinic have caught our patients who have presented with HPP. It has actually been off of the lab monitoring process. And then when you go back and you ask them, you follow up with them, yes, they do have the musculoskeletal symptoms. They have a dental history that maybe wasn't fully investigated, but that's how we have found them. And then I think there's also a misconception that these patients need to be managed symptomatically without additional screening. And so I think there's a huge need for screening all family members for these genetic mutations. And I think that is also something that is misunderstood.
Absolutely. And, and you may be thinking, listener, that, I don't know that I should be responsible for this. But again, if you're doing bone health, which sometimes, these are even young people that are referred to us because they're fracturing, and so maybe it's not necessarily like, can you rule out osteoporosis or whatever? Maybe it's, again, this is a patient that's had recurrent fractures, or, again, they have this chronic widespread, musculoskeletal pain. And it is our job really we might not be the ultimate person that is managing it, or maybe we are, I don't know, or should be. But, again, I think we have a responsibility to our patients to understand what this is and know the workup that should be done. And I think that's why APPs are so wonderful, because I think we are really good at doing this. Wouldn't you agree?
I would agree. I think that we tend to pause as APPs, and we tend to dig into the patient's history. We are very good, puzzle solvers typically, and a lot of patients describe us as having a great ability to really listen to what they're saying. The other thing is, if you're in an element or in your practice where you're doing a lot of bone health, and you have those patients that present at a younger than typical age for osteoporosis management, and something seems a little off, they've had multiple fractures or atypical fractures, consider this in your differential HPP, because most of these patients are going to present in middle age, in their 40s or 50s, which is a little bit different than most of our osteoporosis typical age patients.
Absolutely. That's really helpful. So, okay, so I'm a new provider to rheumatology, or somebody like me who's never really been ordering this and should after 18 years. What can I do, or what can this new clinician that's just hearing this podcast or wants to start to, really delve into this, what are the practical steps that we can all take to incorporate a low ALP awareness into our routine clinical assessment?
Sure. So I think first thing is paying attention to your laboratory values. Don't just gloss over a mildly low ALP. Make sure you follow that up and make that part of a protocol, even if it's not implemented in your clinical setting. Make it your protocol. I would also really put into practice kind of an extensive musculoskeletal history taking approach, including dental health. And that would be what I would do if I were a new APP, trying not to miss the screening of appropriate patients here.
Wow. Well, thank you so much. I think this is going to be really helpful to all of us. And like I said, I can actually think of a couple people this week where I said, oh, you've got this low ALP level. You should probably talk to your primary care about that. Or, again, kind of gloss over it. And really, I should have and will, because I always believe that, learning new things can help us, especially as we move forward, to help potentially, diagnose these people and prevent further fractures, additional things that could really help them, right?
And I think that, these patients are ultimately so grateful because they feel a little bit brushed off by sometimes multiple specialists in multiple areas of medicine or even in their dental setting. And so if you're able to identify this for them, they are just so grateful. And then you also have the potential with doing the genetic screening and then incorporating screening of family members to affect multiple generations in a family by knowing the protocol and incorporating these pearls into your clinical practice as a rheumatology APP.
Absolutely. So not only are we potentially helping the patient, we're also helping the patient's family members that maybe they've been, not diagnosed. So that's so valuable. Well, thank you so much, Heather. I think, again, you obviously know this quite well and you've taught me, and I really appreciate it, as do I'm sure our listeners.
Thank you for having me, Amanda.
Yeah, that brings us to the end of today's episode. Again, a huge thank you to Heather for bringing her expertise and helping us unpack the genetic considerations behind low ALP, an area that continues to evolve and impact how we evaluate and manage our patients. If you found today's discussion helpful, please be sure to subscribe, leave a review, or share this episode with other people that could benefit from it. And of course, stay connected with RhAPP with our upcoming education, new podcast, all things, our content room, and the latest in rheumatology practice. You can go to rhap.org, have our RhAPP ACE app, the content room. It's all housed there. So amazing, all of the work that we continue to do. I just feel so fortunate to be a part of this amazing organization. Thank you so much for joining us, and we look forward to having you back for our next episode. Until then, please continue to take great care of your patients and keep elevating the rheumatology care one conversation at a time.